We need to make sure that not only do we do the best possible research that has an impact globally, but we also bring along society with us, and the society in whichever country we work, because eventually this is a societal problem that needs to have complete societal engagement. But importantly for us, that we wanted to look at it in terms of what does this mean globally, and particularly from the low and middle income country setting. But I also want to flag to colleagues within the UK, having worked in the NHS since the mid-80s, this is not a problem that's out there. This is a massive problem within our NHS, and it's part of our day-to-day lives. And it is really, really, really difficult looking after patients, looking after patient populations, looking after patient pathways, and doing your best for your patients, because this is such an enormous challenge here and now, never mind in the rest of the world. So it's a reality here, and very, very challenging problem within the NHS. And it's really critical that we need to look at this from multiple perspectives. And it's clearly absolutely not about new drugs. Can we just, make that plain? So the name of our network is about antimicrobial optimization, because if we're wanting to deal with this globally and equitably, we have to look at how we can maximize the effectiveness of our existing agents, learn about how we can protect any that might come through, but actually, how can we do the best we possibly can in terms of managing the diseases that matter in different countries, and also with understanding the issues about access and the context of healthcare and the challenges around. So this was the vision of CAMO-Net, and it is an enormous problem. And we need to make sure that not only do we do the best possible research that has an impact globally, but we also bring along society with us, and the society in whichever country we work, because eventually this is a societal problem that needs to have complete societal engagement. So that part of our work, which is about the knowledge mobilization, linking to policymakers, linking to our local patient communities and populations, is also really, really important, and also ensuring adequate representation. So it's a huge problem. It really was about trying to establish equitable research that was driven by local priorities, local needs, and also harnessing the incredible expertise and research track records in these different countries. And coming together to share learning and maximize the input into particular problems that are local priorities, but bringing in learning from around the globe to focus on those priorities, and ensuring that the learning is backwards and forwards. And we've just had 2 great days of some fantastic workshops, and we've been having these repeatedly in the different countries, and it's been really fantastic to share the learning. Andrew mentioned the power of data, really important that we think about how we can use data equitably and build upon this, and also how we can bring the next generation along with us and foster the most incredible collaborations and multidisciplinary working, as it is not just what gets done in the wet lab or by our AI engineers. It's really important that we understand how all these different disciplines contribute to addressing this challenge. And we have got the most incredible expertise around us in all of these different countries. So the locations, you can see them there. I listed them, but this is really important. The other thing is that as well as these different countries, we're using the experience of the countries to drive what we want. What do we want in a global data resource? How do we get the input, the collaboration between, to start with, India, Uganda, and the UK in terms of what would be a good basis for a global data resource to make sure we get representation in terms of how we use antimicrobials? How can we use the phenomenal expertise in genomics, clinical pharmacology, and diagnostics from these incredible centers. So we are using everybody's brains and everybody's talents to work together to address this big challenge for us, for our communities, our families, and our future, and also the survival of healthcare. And, you know, climate change, critically important, but it's going to be a bit of a problem if we survive climate change, but we've got no healthcare because we haven't sorted this out amongst ourselves, or we haven't engaged the young to take it on and help us address it. So we wanted a global approach. We wanted to generate new knowledge, but we want to generate knowledge that actually influences policy. So that's also very important for us, this knowledge mobilization piece. It's not enough to do the work if nobody knows about it and it's irrelevant. So the knowledge mobilization piece is very important, and the ability to influence leaders and policy. So that's been an important part of this work as well. And also to make sure we develop data in a way that can be an open resource for the rest of the world to build upon it, to ensure representation, but informed by expertise and thinking about how we best manage and bring the brains of data science to bear on this. We had a lot of work went into this. This didn't come out of nothing. A lot of discussion, a lot of scoping about what the priorities were in terms of research, a lot of work with Wellcome Trust beforehand, a lot of work looking at the gaps in research, and a publication or two, both the Wellcome and also with the Lancet, and work that Esmita, who's here, brought together about where were the gaps, particularly in looking at antimicrobial optimization. And through that, we developed a roadmap, and through that, we developed the themes within CAMO-Net. So one is around tech and innovation, and a lot of the work in the UK is around that. So that's why the workshops have been kind of tech and innovation heavy for the last 2 days. But part of the tech and innovation is also considering implementation. Who cares about tech and innovation if nobody's going to use it? It doesn't fit in with your how you deliver healthcare in your context, or the public don't want it. So implementation and the co-design of things is a very important part of the tech and innovation, as well as the phenomenal and elegant science and engineering around developing some solutions. Medicines management as well. We need to look at systems-led approaches to how we look at antimicrobials nationally and globally. And also, critically, looking at context, culture, and behavior. And this is at an individual level, an organizational level, and also at a national and international level. So part of what we wanted to do was make sure that there were equitable partnerships across the different countries. And this took a lot of work. This didn't happen out of nothing. Huge amount of work went in to the MOUs, all the admin required to establish these individual countries as individual grant holders. And it was really important that we did that, and the direct funding. Really important we did that with PIs in each country. And so I think this photo, so we've got Liverpool, Accra, and South Africa represented, but I think that was in Sao Paulo at one of our meetings. And we also wanted to make sure that the research is contextually relevant. This is work led by our colleagues in Bangladesh, and you're going to be hearing a little bit more from Senjuti Saha in a bit. And the importance of learning what has already been going on within communities and how we can share that across countries is really, really important, and that the work is relevant to the public health and the public health priorities, and harnesses the research expertise that's already there. So just a little bit about outputs. There's, as well as the kind of fundamental, I want to stress how CAMO-Net is so much more than the research outputs. It's so much more. What has been developed and the platform and the network is so much more than its outputs. But wanting to make sure that people are aware that there are products and outputs, I just wanted to highlight some of the areas which have been particularly productive. There's been a huge amount of work around frugal, point of care, non-invasive monitoring, point of care diagnostics, rapid molecular testing, with incredible expertise from a range of different sites, patents that have arisen from that, as well as many papers. Amazing clinical trial designs, national and global guidelines, but also a huge amount around national and global advocacy as well. So shared learning is at our core, and making sure that we share that in lots of different directions, and also how we are able to exchange fellows to come and work. Earlier on, if you were here, Christine from Kampala was talking about how a member of her lab is over at the moment with the guys in Liverpool and London, and then there's a bit of back and forth there. One of our pharmacy PhDs just spent time in Bangkok, Richard. I mean, so it's been really fantastic, this cross-fertilization of learning. And we're absolutely delighted that we have the opportunity to foster this, facilitate this, and generate a complete ethos of shared learning, collaboration, and I hope that will go well into the future. One of the things that we feel very proud about is actually the input into the training and the development and the capacity strengthening. And that budget was given to Uganda, who are managing all that we do across the different countries. In terms of fellowships, supporting training, supporting specific technical expertise where it's needed. And there's a variety of programs that have been really successful. And this off-site placement and exchange has been particularly useful. And I want to thank our Kampala colleagues for leading on that. Huge amount of community engagement, huge amount of work in Uganda, huge amount of work in South Africa, particularly leading on work around the methods of optimal community engagement, and how we can particularly ensure public awareness and local leadership, in addition to the knowledge mobilization around the specific research outputs. You'll probably hear a little bit more about engagement with policy leaders, but as I mentioned earlier, that it was really important that the national work is not in a vacuum, unattached to the policies and the national action plans. So it was really, really important to us that each country had a method and support to influence policy. And there's some really beautiful examples of this. And this is particularly a lot of work in Uganda that's highlighted here, but in every country, the engagement with policy leaders and government is really, really critical. And there's also work that's supported by the WHO, looking at issues about inequalities in this arena as well. So the future, we really, really think this integrated global approach, driven though by local priorities, harnessing local expertise and national expertise, and ensuring learning in multiple directions is absolutely critical. But the problems are slightly different in different contexts, and that's what we need to recognize. But fostering that shared learning is something I think we've really managed to do. Knowledge expansion, of course, I've already said about national policy influence, but we also want to develop global data resources that can be built upon to drive equitable access and maximize the effectiveness of antimicrobials and how they can be used, but also how we can use this data to drive research questions, answer challenges, but do it in a way that has got the adequate representation and understanding of the different national contexts. So that means quite a bit to us, in addition to the outputs and the research products from this. And I will stop there, and thank you very much indeed. Thank you.
Thank you all. So we will have questions from the audience, but before we take some questions from them, I have a few to get you warmed up. So we'll start with Senjuti. So Alison's given us a really great overview of the CAMO-Net model, and she mentioned that it's really important to have this integrated global approach, but also with the appreciation that we champion local ownership, local leadership, and local priority setting. Could you tell us a bit more about the impact that that's had for you, for your team in Bangladesh, and also the communities that you serve?
We primarily work with children and infections. And to give you a background of Bangladesh, we are a pro-vaccine country. Even if you go to the most remote parts of Bangladesh, our vaccine coverage is over 90%, reaching 95% in most places. And in the last few years, few decades, we have really caught up with the vaccines that are needed. So there isn't really a big difference between, let's say, the immunization program for children in UK and Bangladesh for most part. And we have done absolutely excellent work in reducing mortality of children under the age of 5 years. However, where we have not done great or we have kind of stagnated is when it comes to reducing deaths of babies in their first 28 days of life, so neonates. And one of the main reasons of neonatal death is infections. So in the hospital that our organization works with, Dhaka Shishu Hospital, Bangladesh Shishu Hospital and Institute, we have about 600 beds. And every year we admit over 5,000 neonates. And in about 500 of them, we will detect severe bacterial infections. And more than 30%, so that's more than 200 of them will die due to that infection. And these infections are highly resistant to antibiotics, and these are not hospital-acquired. They're coming directly with the infection. So we have, tried to work with several donors, trying to understand why are these children dying, even in some cases when the antibiotics should work. Are we giving the right dose at the right time? But oftentimes, historically, working on neonatal sepsis has been difficult because every donor or every collaborator that we collaborate with in high-income countries has specific agendas, and the approaches are often surgical, where we will work with one bacteria, try to understand everything about that one bacteria, without realizing that a child doesn't come to a hospital because of one specific infection. A baby comes because the baby is sick, and that could be due to several reasons, could be because of different bacteria. So we basically wanted to understand what are treatments that are currently given, how are policies decided in hospitals, what are the outcomes of this treatment, but we were unsure about how to do that. And that's when kind of CAMO-Net came in. And it was so different in the way that it did not tell us, this is what you do, because this is what some people in the world that do not make up 0.1% of the population think what you should do. But it was like, hey, we are a shadow side. We don't have a lot of money, but we have a lot of freedom where the money was given and said, you decide what you want to do. And, data scientists, epidemiologists, microbiologists got together and we were like, we want to understand what kind of treatment with what antibiotics at what time is leading to poorer outcome or better outcome. And while the money is not a lot, it's going very long because there is local ownership, because clinicians or microbiologists are like, we always wanted to answer these questions. We do not need to be compensated for our work because we understand this is important work. We will contribute, and we know this is sustainable work. So it really is going a long way.
And CAMO-Net is already and will continue to produce really rich, unique data sets. And as Alison mentioned, one of the key issues that we face in this space is translating that evidence into action. With engaging with policymakers, Alison said herself, not enough to just do the work. We need to make sure that everybody knows about it. And in Uganda, there's been so much engagement at various different levels. There's been a lot of national interest at government level in CAMO-Net. I wonder if you could tell us a bit about how the Uganda Hub has managed to engage so well and what that has meant so far and what the benefits will be in the future.
So just a little over a month ago, the Ugandan team had a dissemination event bringing together a diverse group of stakeholders, parliamentarians, patient groups, community, so that we share some of the emerging insights from the work of CAMO-Net, including the economic impact of antimicrobial resistance. I want to thank Alison, who joined online in addressing that group. And in my remarks, I underscored the primacy of action when it comes to antimicrobial resistance. I think the research community in AMR really agrees we have enough data, the gold. So the gold is there, but in Africa particularly, what we really need is to act. And I just want to highlight 2 areas of action that we use that meeting to really focus on. One is around updating existing legislation around AMR. So in Uganda, you can walk into a pharmacy or drug shop and get any antibiotic. You can get a half dose, you can get 1 pill. So the regulation of access to antimicrobial, to antibiotics really needs to be tightened. And what is surprising is that the overarching act around regulation has not been modified for over 2 decades. And so I think the CAMO-Net team in Uganda is learning that it's great to do research, have these great publications in peer-reviewed journals, but now researchers need to get new skill sets of engaging with the right actors for action. And I know I have little time, but I think what we are doing in Uganda is identifying champions within the legislation, what I call the coalition of proactives. So people who are willing to go beyond the talk to really act. My next comment is around public engagement, and the Ugandan hub. The insight I really wanted to share with the team is the institution I had for the last 15 years. We've really been rolling out programs that focus on HIV and AIDS. But I think one of the most beautiful things that has happened in those 15 years is the accruing of trust within the communities, and even changing and challenging some paradigms. For example, the doctor-patient paradigm, which was very vertical, but which we have now learned we should really be in partnership with our patients. So very briefly, Chibuzo, what we've done is we've taken those insights from the HIV space and we brought them into the AMR space. And you did see a photograph where very experienced peer educators and people who use these drugs are the most credible vehicles for conveying information to communities.
Janet, we'll briefly come to you. In the ID Solutions program, our focus is on the communities most affected. And that's really vital to creating meaningful impact. And Andrew has touched on that as well. And it's central to CAMO-Net. To do this well, we really have to be deliberate in how we develop programs. I wonder if you could talk to us a little bit about how this was done by the infectious disease team for CAMO-Net and how that marries in with the rest of the AMR portfolio.
Thank you, Chibuzo. So as a research funding organization sitting in London, it's very easy for us to come up with ideas and set a priority and think that's what we'd like to fund. But with AMR, over time, we realized that it's better when we co-create our research with the communities that are most affected. And that was the central theme when we were creating CAMO-Net as a project. We really wanted to co-create activities with the countries we were working with. And as Senjuti has elaborated, we really wanted to do work that has impact in the community. And it's only possible to do that when you work with the community, with the local teams in creating the activities. In terms of how that comes into our strategy in the ID Solutions program, AMR is one of the key strategic areas in our ID Solutions program. And of course, our core interest is to co-create activities. And we plan to do this within 3 outcomes. The first one of which is improving our understanding of burden, transmission, and drivers of AMR, so as to be able to inform and prioritize the optimized use of interventions for AMR. And I think we've succeeded in doing that through programs such as the GRAM study. The GRAM study has gone a long way in solving a problem for everyone that is affected by AMR by estimating the burden of AMR, so that we can know how many people are dying out of drug-resistant infections in which country and which drugs are most affected by resistance. And it is only when countries know which are the antibiotics at risk in the country, then they can develop context-specific interventions for that specific drug. Additionally, we have done this by developing specific AMR surveillance and monitoring tool, which is the ACON project. And with this, we bring to countries a tool that will help solve country-specific problems in terms of knowing where is AMR when. And so the ACON project makes available a protocol which countries can use to do that. And as Andrew has mentioned, data is gold. And out of both the GRAM and ACON programs in ID, these two pieces of work led us to realize that, in fact, low and middle income countries were missing out on the gold by the fact that they did not have proper data. And this was due to the lack of a systematic data capture tool. And that led us to develop another activity, which again is co-created with countries, which we call CEDRILEMS, which is a tool that is supposed to enhance how countries are capturing data, local data that is specific to the country, and therefore they're able to use that data to solve local problems. And I think Andrew's organization is one of the teams we are currently partnering with to test this tool at the country level to ensure its utility and its ability to be able to solve context-specific AMR issues. The second outcome and how we work with countries, having known all the data having received all the data from outcome one, we then work towards the accelerated discovery and development of novel therapeutics and vaccines. And that work is led by my colleague Sabrina, who will be somewhere in the room. And this is mainly done through the CABEX program, which again works towards developing therapeutics, drugs, and vaccines, and in fact, even diagnostics that are going to be used across countries in order to be able to mitigate against AMR. And lastly, our third outcome is where CAMO-Net sits squarely, which is in the optimized treatment and prevention of AMR. And again, taking a context-specific approach, and I won't say much because it's all been covered by everything you've heard about CAMO-Net today. But in doing all this, we don't sit at Wellcome and do all that in isolation. In doing this work, at the center of our activities is working with stakeholders, especially at the country level. And if you look through our portfolio, you will find that we bring this to the country by working closely with ministries of health, working closely with civil society organizations at the country level. React Africa is also represented in the room. And we also work very, very closely with policymakers, because all of our ID research activities generate evidence. But that evidence has to be translated into action and has to also be translated into policy and action at the country level so that it can lead to the impact that is desired.
So one thing we haven't touched upon, and I'm really glad of that question, was this doesn't happen out of nowhere. And one of the things that we really strive for is not just research excellence, but administrative excellence, project management excellence, and investing in that to support the work intelligently across countries, understanding the challenges of working in academic institutions and some of the different challenges in the different countries. So without that investment in the project management, the administration, and the mutual support across project managers in different countries, we wouldn't be here, we wouldn't be able to do the research, we wouldn't be able to support the training, we wouldn't be able to leverage other funding, and it's absolutely critical that we think about the investment in core administration, effective project management leadership in collaborative research. And I think that's been really, really important. And Chibuzor probably still has the scars on his back from trying to arrange that at the start, because it was a huge amount of work to make sure individual grants and what that meant in terms of agreements. Our project managers in each country are absolutely critical, and the network that they form is absolutely critical. and their development is absolutely critical.
Janet, did you want to add to that?
Just to add a quick one there, I think that most of the time when we fund, we often give funding to a single institution that disburses to the other institutions. I think one unique model that makes it very easy for CAMO-Net is that each of the countries is funded directly. And so they have the autonomy to drive and be responsible and be independent in terms of how they conduct the research. And I think that has really gone a long way in making us able to bring the teams together as independent voices.
So I'll start on that and then hand it to the rest of the panel. So within each country, I mean, one of the things that was agreed at the very start, that there would be one person who'd be responsible for knowledge mobilization. And but the important thing was that it didn't mean that that person had to be a person with a policy background. It could be, if that was, if you've got strength there or individuals there, but it could be one of the researchers, one of the teams, but their role would be to make sure that there was a level of integration, that this was not something that's completely separate from national strategies, national action plans. So that was one way. But the course of that person has not been mandated, but the emphasis that there needed to be one person in each country who should do that was a way of positively reinforcing that.
So, oftentimes as researchers, I'm not a clinician, I work in a lab and I love it. And I sometimes don't want to leave the lab ever. So we forget that it is extremely important for us to work with clinicians, hospitals, stakeholders, policymakers. So I think something also quite unique about CAMO-Net is, I don't know how this happened, but stakeholder meetings are quite mandatory. Every time we have CAMO-Net meetings, CAMO-Net visits, we ensure that there is representation from policymakers, from the head of neonatology, etc. So that also forces us to get into those spaces and talk. And this inspired us. So CAMO-Net inspired us to actually write a grant that's completely focused on policies through stakeholder engagement. So now we have an additional grant from NIHR to do just that.
Yeah, so in Uganda, this was quite easy for us to make sure CAMO-Net work gets integrated. And there were three key things that have facilitated this. One, so my institute, from a strategic posture, all our programs support national priorities and plans. So whatever we do, we're very cautious of our location within Uganda, even though the Institute has regional aspirations. And that's very helpful that the Institute already has national consciousness at the center of the work we do. So that's one. The second one was existing momentum, even before CAMO-Net. So IDI was in a position where we've always had some resources to support the secretariat that puts together the National Action Plan. This is through mechanisms like the Fleming Fund, Resolve to Save Life, and others. And now CAMO-Net really is adding momentum to that. And so it's easy to plug the work we do within that existing framework. And the third one is membership on the national committee that puts that. So our institution has membership on that committee. So it makes, that enables a lot of influence for the things that happen. So that's our experience. Thank you.
I'd like to say thank you again to our panel. Thank you.